Okay. So ada berapa kes ni? Satu je kan?
Satu je doktor
Patient
yang
mana?
hari tu.
Nama dia?
Patient Alisa, 2 months old female girl.
Okay, siapa? 2 months old ni. Okay lah, present lah.
Okay. Okay,
Okay.
Bismillah. So, so my patient today, Alisa, a 2-month-old female girl with underlying perinatal stroke, presented to ED suspect with multiple episodes of seizures with difficulty of feeding on the day.
Sekejap. Dia breaking lah. Sekejap.
Breaking.
Boleh ulang balik tak? Tadi breaking. Okay, start balik.
Okay.
Okay.
Alisa, a 2-month-old female girl with underlying perinatal stroke, presented to ED suspect with multiple episodes of seizures with difficulty of feeding on the day of admission. Okay, history of presenting illness. History was taken from the patient's biological mother. Alisa was having multiple episodes of seizure every day for the past 1 month, but on the day of admission, the seizure was associated with difficulty of feeding. She was unsure of how many episodes of seizure Alisa had for every day, since the episodes were too many to count. Each episode of seizure would happen spontaneously without any triggers. Her mother denied any vomiting before the seizure. There was no fever, irritability, neck stiffness, or any head injury. Each episode of the seizure lasted less than 30 seconds and was described by her mother as jerking of the upper and lower limbs associated with twitching of both eyes. Her mother denied any eye rolling or lip smacking during the seizure. After each episode of seizure, the patient seemed to regain consciousness immediately and continue to do what she was doing before the seizure happened. As for her feeding, there were no urinary and bowel incontinence or cyanosis after the seizure. As for her feeding, she was exclusively breastfed 75 ml every 3 hours normally. But however, on the day of admission, she refused to be breastfed and was only given 180 ml of breast milk that day. Her parents decided that to bring her to ED suspect due to poor feeding. Upon further questioning, her mother mentioned that Alisa had postnatal complications. Alisa had poor sucking effort and was less active at 14 hours of life at Quanta Medical Center and was brought to the nursery. However, she developed rapid breathing and was given oxygenation via nasal prong. However, her condition became worse. She was then intubated and later referred to SUSMED for ventilation. When she was at NICU SUSMED, she was found to have central hypotonia by the doctor there. Her mother also revealed that the patient had the first episode of seizure at day 10 of life. It was described as jerky movements of bilateral upper and lower limbs for less than 30 seconds. On day 11 of life, she had episodes of recurrent facial twitching, and she started with oral Keppra, levetiracetam, twice daily. First MRI of the brain was done on that day and revealed the presence of watershed infarcts in the region of the corona radiata bilaterally and presence of minimal subdural bleed. She was then diagnosed with epilepsy secondary to perinatal stroke. From the first month of life, she started to have multiple episodes of seizures every day. Second MRI of the brain was done on day 52 of life, which reveals the same presence like the first MRI. Systemic review. The general systemic review shows that the patient had poor feeding during the day of admission. There was no fever, lethargy. Sorry, doktor tak dengar. Your sound is voice is breaking. Hello. Alamak.
Hello, saya.
Ni continue, Doctor. Shall I continue?
Sorry. Saya tak tahu asal dia keluar. Boleh tak you start? You repeat balik start daripada after MRI.
Okay. After MRI.
Okay.
Okay. On day 11 of life, she had episodes of recurrent facial twitching, and she started with oral capra twice daily. First MRI of the brain was done on that day and revealed the presence of watershed infarcts in the region of the corona radiata bilaterally and presence of minimal subdural bleed. She was then diagnosed with epilepsy secondary to perinatal stroke. From the first month of life, she started to have multiple episodes of seizures every day. Second MRI of the brain was done on day 52 of life, which reveals the same presence, just like the first MRI. On systemic review, general, the patient had poor feeding during day of admission. There was no fever, lethargy, or any loss of consciousness. Neurological systemic review, there were multiple episodes of generalized tonic-clonic seizure that lasted for less than 30 seconds without triggers. It was associated with twitching of both eyes. There was no eye rolling, lip smacking, neck stiffness, or any change of behavior. Central cerebral vascular system, there were no cyanosis, no reduced effort tolerance or fainting episodes. Respiratory exam, there were no cough, no runny nose, no wheeze or dyspnea. For GIT, there was no nausea, vomiting, diarrhea, and constipation. Genitourinary system, there were no change in urine frequency or color of the urine. Hematological, there's no bleeding tendency such as gum bleeding, nose bleeding, or bruises noted. Skin examination, there was no rash or ulcer or pruritus. Past medical and surgical history. This is her third hospitalization. Her first hospitalization was during the third day of life. She was admitted for 1 month at NICU Susmet due to central hypotonia secondary to perinatal stroke. She was referred from KMC as she had poor sucking effort and was less active on first day of life, and later developed rapid breathing on the third day of life, which requires intubation. She was ventilated for 11 days. She has also been diagnosed to have epilepsy secondary to perinatal stroke, as she had her first seizure on day 10 of life. Her second hospitalization was on 30th of May, as she was electively admitted for second MRI of the brain. For drug history, she is currently on oral capra, levetiracetam, oral phenobarbital, oral clobazam, and supplements such as maltopher, folic acid, and multivitamin. There was no known drug allergy. For birth history, her mother was diagnosed with mild anemia since early pregnancy, with hemoglobin level ranging from 10.1 to 10.8. Otherwise, there was no history of medical conditions during pregnancy. For intrapartum, Alisa was delivered full term on week 38 of gestation via spontaneous vaginal delivery. The delivery was uneventful. Her birth weight was 2.9 kilograms. Postnatal, Alisa was admitted to NICU Susmet due to the respiratory distress and less active. And starting from the third day of life, because of the otherwise there are no other complications were known. Immunization history, she completed her immunization up to her age. Developmental history. The patient has a delayed developmental milestone and was not appropriate for her age. Her developmental age was less than 6 weeks. For gross motor, she was unable to turn over and still showing head lag, fine motor and vision. She was unable to grasp objects and her eyes are unable to follow objects yet. Her speech, she was unable to respond to sound. Social, she could only smile and laugh while sleeping, but not doing so when she was awake. There was no social smile yet. For nutritional history, according to the mother, she was exclusively breastfed until now. She normally breastfed 75 meals every 3 hours. There are no known food allergies. For family and social history, she is the first child. Her mother is 25 years old, works as a saleswoman, while her father is 28 years old, works as an executive officer at Petronas. They live in Bukit Istana and their household income was around 8,000 ringgit per month. There was no family history of seizure or epilepsy, and there was no history of malignancy known in the family. For physical examination, it was done on the second day of admission. Alisa was conscious and alert. She was not tachypneic and not in respiratory distress. She was not lethargic or in pain. There was cannula attached to her left dorsum with no active infusion. There was no central cyanosis or scleral jaundice. There was no clubbing, peripheral cyanosis or stigmata of IE. The hydration status was good. The vital signs show that her temperature was 36.6 degrees Celsius, febrile. Pulse rate was 124 beats per minute, normal. Tendency. Her SpO2 was 100%. Her blood pressure was 91 54. Systolic 54 diastolic. Normotensive. Her for autophometric measurements, I didn't measure the height and circumference because I didn't measure the height and the head circumference because the patient was crying when measuring the patient. For neurological exam, on inspection, there was no muscle wasting, involuntary movement or tremor. Fasciculation was not assessed. The tone was normal and the power of the upper and lower limbs were at least 3. Tendon reflexes were not done. For summary, Alisa, a 2-month-old female girl with underlying perinatal stroke, presented to ED suspect with a history of multiple episodes of seizure with difficulty of feeding on the day of admission. There was no eye rolling or lip smacking during each episode. It was not associated with fever, vomiting, post-ictal drowsiness, or neck stiffness, and no history of head trauma. On physical examination, the tone was normal and the power of the upper and lower limbs were at least 3.
Hello? Dah habis lah?
Yes.
Okay.
Doctor, we couldn't hear you.
Hello, dengar tak?
Dengar, doktor.
Assalamualaikum. Dengar tak?
Salam. Dengar, doktor.
Sorry, dia tahu dia macam 4G. Line okey je tapi tahu putus-putus lah. Anyway, so your diagnosis? Next time kan, after summary, you just continue with diagnosis. You tak payah tunggu examiner ataupun lecture you prompt. So you just continue with diagnosis.
Okay. So my provisional diagnosis would be epilepsy secondary to perinatal stroke. So my points for was there was history of infarct in the brain shown in the last MRI scan, and there was there was episodes of generalized tonic-clonic seizure every day for the past 1 month. So for my points against is that there was no family history of epilepsy.
Lagi?
So
Any differential?
and for my differential will be cerebral palsy, because for my points for is that the patient has a recurrent seizure which was epilepsy for every day, and there's also history of the patient has central hypotonia. So my points again would be there was no family history of cerebral palsy.
Okay, good. Actually, I want to ask one question. All the terms kan yang you use is by mother ke ataupun you tengok this system? For example, like the MRI kan, watershed region, bilateral watershed region infarct, and then the central hypotonia. Is that
Yang
offered by mother ke ataupun
yang hypotonia tu mother sendiri yang sebut lah.
yang
Yang
watershed infarct tu?
yang MRI tu patient punya mother cakap stroke je, yang watershed tu tak.
Okay. So tak apa, next time you tak payah present lah kalau dia tak ada sebut watershed infarct tu. Just say just quote any information yang you dapat daripada parents. Later on, and kalau you nak cakap boleh, you kena mention from the notes, it is written that the child got watershed infarct bilaterally from the notes lah, ataupun daripada buku patient, from logbook ke. Kau tak, nanti kita tak tahu which information you dapat daripada mother, which information yang, because we are assessing your presentation, means partly we are assessing your clerking skill kan. So if you got all this information from mother, so that's very good lah. Tapi kalau you tak boleh mix up lah semua benda daripada buku ataupun daripada notes, so I'm not going to be able to truly assess your clerking skill. Tapi anyway, so that's okay. So let's start with Afiq Nasir. So what do you think about the presentation?
Doctor,
What good about the presentation? Huh?
Doctor, I'm the presenter, Afiq Nasir.
Oh, bukan Abdullah Hakim.
Oh, bukan.
Abdullah Hakim tu Raylan. Oh, okay. So Abdullah Hakim. Because nama Abdullah Hakim tu keep on appearing kan dekat luar, dekat depan screen.
Okay.
Okay, Abdullah Hakim.
I think the presentation was good. The flow is okay. The description of the seizure was quite comprehensive. The before, during, and after. I think for improvement, maybe the physical exam maybe, because you didn't measure the head circumference and the height or weight. I think that's all.
Okay, good. Aida Sabrina.
I agree with Abdullah Hakim. The flow is great, it's easy to follow, and then the description of seizure is also quite complete, I think. But what can be improved is that from your HUPI, I was just confused as to why the mother wasn't worried that the seizure occurred to her daughter for the past 1 month. And then, like, did the mother give any medication after that, or what did the mother do after every episode for the past 1 month? Maybe I would like to know more about that. And then, maybe you can put like the negative symptoms in the HOPI as well, like whether the patient has any lethargy or any dehydration symptoms due to poor feeding at the dry lips kata reduce urine output in the HOPI. Other than that, I think it's
Okay, okay, that's very good. Okay, so I agree with all the comments. So in general, the presentation is very good. The flow is clear. I can see your thought process. And then you didn't miss any of the domains of history taking, like of history. All are presented very well lah. Developmental history, vaccinations were clearly mentioned. In fact, the history, the flow of the history is quite good. That we know which one is the past, which one is the present, which one is the current. Very good lah. I think that's very good. However, there's few things I would like to add. First of all, because this is something retrospect. When did you plot the case? On Thursday, yeah.
Yes.
Thursday. So you've got plenty of time to arrange your talk, kan? So bila you start formulating your presentation ni? You arrange your presentation for the past few days lah.
Past few days I start prepare tu on right after we clear.
But then you improvise, kan? You practice and then you
Yes.
improvise.
Yes.
Okay, that's very good. So when we do things like this, I mean when things are done retrospectively and after a few like training and repetition, kan? So we will what good about this is you are very well prepared and then you will rearrange your presentation, kan? Cuma the problem is you will insert your analysis. Sometimes what happen is you will be guided by your presentation will definitely be guided by your diagnosis. Betul tak? Because your diagnosis is epilepsy, kan? Because the whole presentation is mainly about epilepsy, kan? The problem with this is if you got wrong diagnosis, then the whole presentation, especially the HOPI lah, will be affected because it will be guided by your diagnosis. So kalau diagnosis wrong, then the whole HOPI will be wrong lah. Faham tak? Because in this case, okay, I always tell this to my student lah. Okay, your diagnosis has to reflect your presenting complaint, and you don't get distracted by the underlying comorbids ataupun by the complexity of the patient. You know what I mean? Understand tak? Because in this case, this patient is very complex. Okay, this is a chronic disease lah. We can call it chronic dah 2 months, kan? So we know the child got underlying epilepsy. In fact, you can present earlier. You can just start underlying epilepsy because the diagnosis is not epilepsy because we know the diagnosis already is epilepsy. From what you presenting, kan, budak ni dah ada brain insult, ada very uncontrolled seizure, refractory seizure. So we know the diagnosis the child memang ada epilepsy. So that's not the diagnosis for the current presentation, current admission. So your diagnosis should reflect the acute presenting complaint. Okay, if I want you to revise your diagnosis, what would be your diagnosis? Because clerking chronic patient is difficult lah, because you tend to distract by the underlying problem lah. When in fact your diagnosis, because we are managing patient acutely in hospital, so we are managing the acute problem. The chronic problem can be managed as outpatient. I give you example lah, okay? You ada satu patient datang dengan asma, okay, with underlying asthma. We know dia ada very poor control asthma. And then this time dia datang dengan rapid breathing lah, sudden onset of rapid breathing, cold induced. Okay, this patient memang ada very poor control asthma. Every night kena ambil MDI, every week ambil naps. But this time dia sangkut, so kena admitted lah because require multiple naps, moderate exacerbation. So what would be your diagnosis kalau this kind of case?
Moderate. moderate exacerbation of bronchial
Moderate
asthma,
EBA kan? Moderate
moderate
EBA.
ABA with fully control.
Yes. With underlying fully controlled asthma kan? Faham tak? So in this case, you cannot put diagnosis as epilepsy because we know this is epilepsy. So what would be your diagnosis? Because the diagnosis should reflect the acute presentation. Unless in exam, where we call patient yang cold case. Contoh patient memang ada thalassemia. So datang, you clock the case. Then you can put the diagnosis as thalassemia. So my diagnosis is thalassemia with chronic hemolysis, for example kan. Macam tu lah. Patient presented, tapi you akan start dengan patient came for examination atau patient came electively for outpatient follow-up. Then with underlying, the diagnosis would be thalassemia, chronic thalassemia. Faham tak? Stable chronic thalassemia. Benda macam tu lah. Tapi kalau in yang asma ni, so in this case, how you revise the diagnosis? How would you revise the diagnosis? Cuba
Maybe
try.
epilepsy with generalized tonic-clonic seizure.
Epilepsy still something chronic.
Uh,
Because dia masuk ward tau. Bila masuk ward, and this is not an elective admission, because for example lah, kalau you clock this case about 3 weeks ago, about 1 month ago when she was admitted for electively for MRI kan, then your diagnosis will be epilepsy. Tapi this time this is something yang unplanned admission. So mesti ada some element of acute condition. Anyone would like to try? Anyone? Based on the history daripada Faris tadi. Good. So it can be URTI lah. So your diagnosis would be URTI with poor oral intake with underlying uncontrolled epilepsy with refractory seizure. Okay, faham tak? Faham tak Faris?
faham.
Because what is your presenting complaint?
Poor feeding.
Poor feeding kan? So in your diagnosis, what in your diagnosis, what are the things in your in what diagnosis can you make to answer the question of poor feeding? Faham tak? So how would you revise your diagnosis now based on your history?
So your RTI with underlying epilepsy.
Okay, good. Okay. So that's why Aida tanya a very valid question asked by Aida just now kan. Because you already in your brain you already put the diagnosis of epilepsy kan. So your HOPI are quite restricted lah, not that extensive. But otherwise the whole history is very good. However, you can improve on your HOPI. So things that should be included in your HOPI are the symptoms and signs that can actually help to helps us to understand what are the cause of poor feeding, and should include all the negative lah. So in your HOPI should be ada fever ke tak, ada diarrhea, vomiting, ada ill contact ke, ada contact with ill people kan, ada UTI symptoms. You should focus on that rather than the seizure. Okay, faham tak? Faham kan? Okay, because at the end the diagnosis is in this case actually the diagnosis is actually the poor oral intake is mainly because dia ada uncontrolled seizure. When you got seizure, what happened? Bila someone got seizure, what happened to them?
Patient feels lethargic.
Lethargic kan? Dia ada post-iter kan? Just imagine lah, dia ada every minute dia ada seizure. Every few minutes seizure. So dia akan jadi very tired. So dia akan very lethargic, dia tak akan minum kan? So they won't be able to drink or eat because they are very lethargic. So the diagnosis in this case, the problem in this case is actually uncontrolled seizure that leads to poor feeding. Okay, so the full diagnosis, I would put as breakthrough seizure. So breakthrough seizure with possible status epilepticus lah. It could possibly status. I think this is status lah sebenarnya. Breakthrough seizure with possible status epilepticus, complicated with poor oral intake, ataupun complicated with dehydration lah, kalau dia ada dehydration, complicated with dehydration, with underlying of poor control epilepsy ataupun refractory epilepsy. Okay, faham? Faham Pak Faris?
Betul.
Okay, so otherwise that's very good history. Ada soalan tak?
Doctor, can we just say that this patient got CP, and also when we can say the patient is undergoing symptomatic epilepsy, as this patient also have positive in imaging?
Okay, there's some. Okay, first kan ada two questions. Very important question lah. Satu about CP kan. So what is CP? How do you define CP?
Apa maksud dia, ada abnormal motor development
Okay,
since
good.
birth.
In? Ya ke? Yang tu je ke? Apa lagi diagnosis CP? The whole diagnosis of CP. CP is abnormal motor development secondary to insult to the developing brain. Okay, remember that's the keyword. Dia mesti motor and then dia mesti insult to developing brain. Okay, so in this child, can we say it's CP?
Can
Okay.
central hypotonia.
Okay, dia tak boleh sebab CP ni, okay, CP is diagnosis after 2 years old. Kita boleh diagnose CP after 2 to 3 years old lah. Biasa 3 years old lah. Because brain ni, the child brain, dia very plastic tau. So maksud dia, they can compensate very well because they are developing brain. So what happens sometimes if a child got accident kan, you've got a baby 1 month old, 2 months old got accident at the right side kan, right temporal lah for example. The left temporal can actually become so plastic that it can actually take over the role of the left brain. Faham tak? So end up, maybe initially you get a very bad neurological outcome kan, but subsequently they can improve and over time they may turn up normal. Faham? They may even turn up normal. That's why we take the cut-off point of 3 months, 2 to 3 years, because that's when the remodeling of the brain stop. Faham tak? So that's only when we can fully assess what is the deficit experienced by the child. Faham tak? Faham kan what I mean kan? So at this age you tak boleh kata dia CP. We don't know. Dia mungkin delay lah, definitely dah ada delay. Tapi we don't know whether this will turn out to become CP atau tak. Especially when the neuro exam normal. Okay, kalau neuro exam dia abnormal, that still cannot be labeled CP because it may normalize because of the brain ability, Faham tak? So it may normalize. So usually we only label CP after 3 years old. After 3 years old kita akan label CP. Tapi before that, kalau patient memang ada obvious features of CP and is progressing. Contoh macam now you see the child dia kan tak ada eye contact kan, tak ada fixed follow, not fixed following, tak ada apa lagi, not even smile kan. So we anticipate and then the movement pun memang ada positive of movement, then we anticipate the child most likely is heading towards CP. And then after 2-3 months you tengok patient again, dia dah ada hypertonia or hyperreflexia, then you know this is an evolving CP lah. So you are quite confirmed, you are quite certain that this will turn out to come CP. Tapi you won't label CP dulu. Some people they use the term like evolving CP atau possible CP macam tu. Tapi kita tak akan guna CP until dia 3 years old. Faham tak? So in this case, you boleh lah kata dia evolving CP. I think that's the better word to use. Evolving CP. Ataupun a child with high risk of CP. Of developing CP. Okay, faham That's number 1. Number 2, epilepsy. How do you diagnose epilepsy?
To afebrile seizure or unprovoked seizure.
Okay. Ada tak dalam diagnosis of epilepsy? Ada tak dalam diagnosis epilepsy patient with brain insult tak boleh dapat epilepsy. Atau ada dia kata apa tu? Febrile seizure more than 2 bising lah. More than 2 episodes of febrile seizure with normal brain, ataupun ada more than 2 episodes of febrile seizure with normal development. Tak kan? Because epilepsy is anything, it's a syndrome. So the underlying cause has to be investigated. It can be anything. Dia macam CP lah. CP underlying cause boleh macam-macam kan. Boleh jadi extreme prematurity, brain insult, infection, perinatal insults, hypoxic insults. These are the causes of CP. Tapi the diagnosis of CP tu dia just a syndrome. So kalau patient ada hypotonia, hyperreflexia, ada dystonia, okay, then you boleh kata this is CP. Tapi the underlying causes is different in every patient. So sama like macam epilepsy. Epilepsy can be syndromic epilepsy. It can be non-syndromic epilepsy. Or it can be epilepsy secondary to brain insults. Epilepsy secondary to MVA. You ada MVA and then ada brain damage, then develop seizure. Then that is still called epilepsy. So in this baby, despite the other brain lesion, this is symptomatic epilepsy because you know the MRI are abnormal. You've got explanation for the epilepsy. So this is a pure symptomatic epilepsy lah. So but usually we say epilepsy secondary to perinatal stroke. Okay, faham?
Doktor.
Okay, good. Okay, ada soalan lagi? Any other questions?
Doctor, just like to ask about this patient. So if this patient has an early onset of like epilepsy, so is there any chance that the epilepsy could resolve in this patient?
Okay. There are a few prognostic factors lah yang kita that can help us predict the outcome lah, the long term outcome. Okay, number one, if there's a brain pathology, chances are this will not resolve. Usually a child with brain pathology kan, symptomatic epilepsy, okay, they usually will become refractory seizure. Definitely akan perlukan 2-3 antiepileptic. Macam budak ni dah 4 antiepileptic. Unless what good about this about patient with symptomatic epilepsy ni with a brain lesion, unless they undergo surgery, then they may they may achieve remission. If not, they will become most of the time refractory epilepsy. That's number one lah. Kalau ada brain lesion. Second, kalau this is a known syndrome. Contoh you buat EEG, you nampak ada specific syndrome. Contoh EEG pattern dia memang Lennox Gastaut punya pattern. Ataupun West syndrome, infantile spasm, memang ada specific diagnosis. Dia memang epilepsy secondary to epilepsy syndrome lah. Then you know this, so you boleh predict dia punya diagnosis. Contoh kalau this is memang West syndrome ataupun infantile spasm, EEG dia memang Lennox Gastaut, dan you tahu patient ni memang akan end up vegetable lah. Dia akan jadi vegetative state, akan regression, and then dia memang refractory. Ataupun contoh you tengok, atau budak contoh 7 years old datang dengan absence seizure. Then you buat EEG nampak benign Rolandic. Okay, features dia macam benign Rolandic punya EEG. Then you tahu this is very benign, after 1-2 years dia akan resolve. Okay, so it depends on the underlying pathology and also diagnosis. Because remember epilepsy, CP, these are all syndrome. Nephrotic syndrome, these are all syndrome. The underlying pathology tu yang akan determine the prognosis and also the treatment. Faham tak? Contoh you ada patient with nephrotic syndrome. You ada 5 patient with nephrotic syndrome. And then you buat biopsy semua. Okay, which one would you, daripada 5 patient kan, which one would you anticipate like total remission, atau which one yang akan ada end up become end-stage renal failure and then dialysis. So you do biopsy and then you tengok, satu ni messenger proliferating, satu ni focus FSGS, another one is minimal change disease. So daripada tu you tahulah FSGS memang confirm lah dialysis. Yang messenger proliferating ni chances maybe 50% dialysis. minimal change disease, unlikely lah dialysis. Usually it will terms like remission. Tapi all that diagnosis is neurological syndrome. Faham tak? Okay kan? Okay, ada soalan? Okay. Okay lah, kalau tak ada last soalan ke?
Doktor, sebelum ni kan yang
Hmm.
apa tu for this presentation, boleh tak kalau nanti kalau esok ke saya jumpa doktor untuk ambil signature doktor sekali dengan markah.
Boleh je.
Nanti saya contact doktor pula.
Okay. Tapi saya dekat NICU esok.
Oh, okay.
So just call lah, just call. Tak, saya dekat klinik esok Isnin kan?
Isnin.
Tak. Okay, sorry. Esok sampai Rabu saya tak ada sebenarnya. Saya ada course. I will be in the hospital lah. Most likely I will be in the hospital. Tapi you kena call lah. Tengok I kat mana.
Sekejap je doktor.
Okay. So call je lah. Okay.
Okay.
Good. Okay, good job. Okay, kalau I think if you guys can present this way kan, definitely you'll be successful lah. In fact, if you continue presenting like this way until the specialist, it'll be very good. Okay. Kita tanggung atas speaker for answer to us. Okay, assalamualaikum warahmatullahi wabarakatuh.
Salam. Thank you, Doktor.
Thank you doktor.
Thank you, Doctor.